It now gives me very special pleasure to introduce Dr. Kenneth Fader. Dr. Fader is a very recent graduate of the Department of Mental Health's PhD program. Indeed, he defended just last month, and he's my first doctoral student to do so. I don't have other doctoral students that should have and didn't. He's just my first. He's my first doctoral student, period. And he did it. Dr. Fader is interested in how public health programs and policies can better meet the needs of families with children where a parent is struggling with a mental health problem or a substance use problem. He will be presenting the results of some of his doctoral research on parent opioid use and its impacts on children. Please join me in welcoming Dr. Kenneth Fader.
All right, I'm going to check in to make sure. Okay, that's what that does. Okay. All right, thanks very much. Like Dr. Letourneau said, my name is Kenny Fader, and I am a 3-week graduate of the Department of Mental Health here at Johns Hopkins. And as I was sitting in that chair, I realized to myself, I just put this presentation together, and I left out the acknowledgement section. So before I even start, Dr. Letourneau has been the most extraordinary advisor. I'm sure anybody who is here knows the incredible work she does, but in addition, she's just been an incredible mentor to me, supported so much research. We'll talk a little bit about this here. So Elizabeth, thank you. So what I'm going to talk about today is, I think, a little bit different than what a lot of the other presenters are potentially going to talk about today. But I hope that it's something that will be of interest to the audience, in part because this is just such a major public health challenge that the country is confronting right now, that I think it has implications for the work that so many of us do. And in particular, I hope to convince you, has important implications for child welfare, and that there are things that we can do about it as child-serving professionals, child welfare professionals, to meet the needs of the children affected by this epidemic and prevent potentially additional harms to children resulting from it. So I'll be talking about meeting the needs of children affected by the United States opioid epidemic. And since this is not a substance use focused forum, I want to start with just a little bit of basic background on what is the opioid epidemic. So what are we talking about here? Why should we care about it? So as most folks in this room are probably aware, the United States is currently experiencing its worst ever epidemic of drug-related problems. And that epidemic is being driven primarily by opioid drugs. And there's been 3 waves of this epidemic, driven by sort of 3 different classes of drugs. So the first wave, which started even as early as the late 1990s and continued through the 2000s, was driven primarily by misuse and overdose death from prescription opioids. And this wave of the epidemic was primarily driven by increases in prescribing of these prescription opioids for chronic non-cancer pain conditions. Now, starting in 2011, what we start to see is, as efforts ramp up to really try to get this problem under control, many people who have already developed an addiction to opioid pain relievers start switching to heroin. And so we see a second spike in overdose deaths and opioid-related problems related to heroin as people who have developed their addiction from prescription opioids switch to illicit drugs like heroin, as access to prescription becomes potentially more restricted or difficult. And then in 2014, what we start to see is a third very large spike in overdoses, specifically related to the introduction, we think, of synthetic opioids like fentanyl, which most of you have probably heard about from the media at this point or from your work. Fentanyl is an extremely potent synthetic opioid that has increasingly become mixed with other opioids. And so people who already have developed an addiction and maybe have been using for years are all of a sudden overdosing and dying. And we've reached the point where something like 2 million Americans are probably living with an opioid use disorder. And in 2017, around 72,000 people died from a drug overdose, which, just for perspective, is more than the number of people who died from either motor vehicle crashes or firearm injuries put together. So most of what you'll hear about this epidemic is about preventing adult overdose, and that's an incredibly important topic, and that's not what we're going to talk about today. Instead, we're going to talk about what about children, right? So most of the focus of this epidemic is on adults, but there's a number of different pathways by which these kinds of challenges that adults are facing as they struggle with an opioid use disorder may be spilling over and affecting children growing up in families or communities where this is a challenge. And so I just want to start by highlighting 4 of these potential areas for increased risk. So the first, and we're not going to talk too much about this, is youth drug overdose. So this is not the focus of this presentation, but we have to at least acknowledge that drug overdoses are up among adolescents and young adults as they are in the larger adult population. The second, and this is the one I think that's received the most focus in the child welfare world, is increased use of substance use during pregnancy. So we've seen an increasing number of women who are using opioids during pregnancy, who are using opioids illicitly during pregnancy, and whose children are being born with something called neonatal abstinence syndrome, which is a syndrome where a child is born already physiologically dependent on opioids because of use during pregnancy. And as a result, they experience the symptoms of withdrawal, and they have to be weaned off the drugs after they're born. And as I said, this has received a lot of media attention and a lot of concern from the child welfare world. But its long-term harms are actually not as well established as we might think. So it's not entirely clear whether any lasting effects that we see in children who've gone through this are linked to the drugs themselves, or they're really related to co-occurring harms that commonly occur along with substance use. Things like poverty, exposure to domestic violence, smoking tobacco or drinking alcohol at the same time as parents are also using opioids. So this, I think, is received a lot of attention. Effects may be important open research question. Now, what's received a lot less attention, but that I think is actually pretty substantially supported, is the risk of maladaptive parenting behaviors throughout the course of childhood. So we know that there's a substantial body of research on substance use while parenting, and that this increases the risk for insecure attachment between parent and child, because substance use, most substances that people misuse act on the same brain receptors that are responsible for the sensation of euphoria that plays an important role of bonding between parent and child. And so opioid use can potentially disrupt this attachment formation, which has lasting developmental consequences. In addition, there's a risk that, parents are going to be unable to adequately supervise their children if they're misusing opioids. This, in turn, has been shown to increase risk for neglect and potentially for unintentional injury. And indeed, in communities with more opioid-related problems, we do see more unintentional injuries to children. And finally, and I think pertinent to this audience, there's a risk that as parents become involved with opioid-related problems, they in turn increasingly associate with dangerous partners. And if they're unable to protect their children from those partners because of drug use, this increases the risk children will be exposed to abuse. And this is a common problem that's been described in qualitative studies of parents who are in addiction treatment, and in turn increases risk for intentional injury, which has also been shown to be associated, to be elevated in counties with high levels of substance use related problems. So this receives less attention and less funding than substance use during pregnancy, but arguably has more long-term behavioral health consequences that are well supported by science. And then last, I want to particularly highlight the problem of extended separation, which we're going to talk about quite a bit today. Because the risk here, right, is that children can experience extended separation from a parent because a parent dies, but also because a parent is incarcerated, because they have to go into residential treatment, or because the child is placed in foster care. And we know that this has lasting, damaging, is a traumatic experience for children with lasting psychological consequences. But I think it's important to emphasize that for the most part, with the exception of death, this is a consequence of how we as a society are choosing to respond to parents' opioid misuse. It's not a direct impact of the drugs themselves. This extended period of separation is an additional trauma that's created by the way our society responds. And so what we'd like to think about is there a public health approach? Is there another response that can help these families heal and prevent the necessity for this separation and for the more draconian levels of child protection? So what should be done? Well, I want to briefly start by highlighting the main approaches that a lot of states, jurisdictions, the government, these are sort of what I would consider the three big buckets of public health approaches that are being designed to address the opioid epidemic, primarily with a focus on preventing overdose deaths, okay? So what are these approaches? And we should think about whether they make sense for children. So the first are prevention approaches, and these basically are probably the ones you've heard the most about. They're about trying to improve prescribing practices, right? So trying to prescribe fewer opioids in cases where they're not necessary, and then prevent diversion of opioid-related drugs onto the secondary market, and engage in drug interdiction, all with the goal of preventing new opioid addiction cases. This is probably what gets the most attention. Second, and very well supported by evidence, is we have a situation where there's already 2 million Americans who are struggling with an opioid use disorder. So prevention alone is probably not sufficient. These 2 million adults need access to evidence-based treatment. And we'll come back to this, but the best supported treatments for opioid addiction are what are called medication-assisted treatments, which is treatments where we help people manage the symptoms of their addiction with the use of supportive medications, and also improve pain management. And so these are strategies that also have been used to prevent overdose death. And finally, while I won't talk too much about it, it's important to remember the third piece of this triad is harm reduction strategies like Josh talked about earlier. Things like naloxone distribution, syringe exchange programs, which don't prevent addiction, but are designed to prevent the associated harms, like the spread of HIV or overdose resulting from. Okay, so which of these policies might we expect to be effective for children? Well, it's not entirely clear, right? Because all these are specifically focused mostly on trying to prevent overdoses for adults. And so we decided to take a look at a test case for these prevention policies as part of my dissertation. Specifically in 2011, Florida adopted a lot of some of the policies that we might think are best practices. So Florida had a major problem with prescription opioid overdose deaths. And so what they did was they established a new prescription drug monitoring program, which gave physicians more access to more information about their patients' past opioid prescriptions and allowed them to sort of be better stewards of pain medication. They also established new standards on independent pain management clinics, which were commonly referred to as pill mills. They said that they had to be owned by doctors and that you couldn't operate an on-site pharmacy, things like that. They were designed to establish some basic quality standards. They participated in a major DEA enforcement action. So after these changes, more than half of all the pain management clinics in the state of Florida closed. And opioid prescriptions fell for high-volume prescribers and high-volume users. So we wanted to answer the question, first, did this make a difference for preventing adult overdose? And there already was some evidence that it did. And second, did this have any secondary benefits of preventing child abuse and neglect? Because of all the reasons we just described, opioid misuse might be related to child abuse and neglect. And so we did this using exactly the same data sets that Reshmi just talked about, the National Child Abuse and Neglect Data System, to calculate rates of physical child abuse, sexual child abuse, neglect, and foster care entry in the state of Florida, and then 13 other control states. And in addition, we used publicly available cause of death data to look at drug overdose mortality. And then what we did is we used a machine learning technique where we used 13 other states to try to forecast what would have happened in Florida if they hadn't put in place these drug interventions. In other words, these states didn't put into place these interventions. So we look and see what happened in those states, and then we try to project what would have happened in Florida, and then compare that to the truth on each of these outcomes. And what we see, and these graphs are a little quick, we're moving quickly here, so I just want to come over here and highlight. But basically, this top line here shows the drug overdose outcome, right? So here is the observed drug overdose deaths in the state of Florida. And here's our machine learning projected what would have happened in terms of drug overdose based on other states. And so it looks basically like it worked, right? This policy actually was effective for preventing drug overdose deaths. But now we apply that same method to child welfare outcomes. And what we see is essentially no change, that these prevention policies were effective for preventing overdose, but it doesn't appear that they prevented child welfare involvement. Okay, so what should be done if these prevention approaches aren't really sufficient to meet the needs of children? Maybe because maybe this is not benefiting adults with children. Maybe it's because adults who are using heroin who are caught up in the child protection system, whereas these policies target prescription opioids. What should be done? Well, okay, let's go back to talking about medication-assisted treatment. So what is medication-assisted treatment? So these are medications like buprenorphine or Suboxone, which are specifically designed to prevent the symptoms of opioid withdrawal. And the agonizing symptoms of withdrawal are maybe the primary driver of relapse and continuing to use during an addiction. And there's now an overwhelming body of evidence that shows the treatment that supplements traditional counseling with these medications and that use of these medications increases treatment engagement, reduces overdose risk, reduces risk for relapse. There's also a substantial body of evidence that shows that when these treatments are used for pregnant women who have an opioid addiction, this improves health outcomes both for the mother and for the child because it helps mothers remain engaged in perinatal care. And finally, there's recent research, not conducted by me, but by others, that shows that when families are involved with the child welfare system and they have an opioid addiction and they're receiving this medication-assisted treatments, they are less likely to have their children removed from their home, and they're more likely to be able to have their children safely in their custody. So something wild kind of happened with my arrows here. I apologize for that. So we actually, this is unlike some of these prevention policies. This is actually a strategy that seems to work for children and to prevent those kinds of extended separation and harm to children we described. What's needed to actually make it happen? So what's needed first, the centerpiece of meeting the needs of families, I think, is the behavioral health system, right? So families need to be able to access and utilize medication-assisted treatment, also pregnant women, and have comprehensive maternity care accompanying that. But in addition, we need collaboration between these three sectors to actually make this happen well. And Dr. Letourneau and I have argued elsewhere in a paper, right, that this means child welfare agencies work to facilitate access to this evidence-based treatment and then subsequently provide the kinds of parenting supports and family-specific supports that treatment programs alone aren't able to provide. And that courts provide programs like family drug courts that help divert families away from either criminal proceedings or traditional custody proceedings and into the kinds of programs that provide incentives for families to remain in care so they can recover and retain custody of their children and prevent the kinds of risks that we discussed earlier. Now, the problem is that there actually are substantial challenges to this collaboration. So, starting with the child welfare side, there's very low knowledge about quality substance use treatment among many child welfare professionals, child welfare researchers. It's just not the focus in the child welfare world. And in particular, there's often a stigma against these medication-assisted treatments. So there's a belief that this is just, quote, substituting one addiction for another, which runs directly counter to what is understood based on medical evidence. And so that means families aren't necessarily referred to the best treatment programs if child welfare providers aren't able to distinguish good from bad. And also child welfare agencies, as I think most folks know here, operate on very constrained timelines, and those timelines might be inconsistent with federal guidelines. Now, on the behavioral health side, we see a problem where there's a real shortage of treatment providers. So even if you want to refer to an evidence-based treatment provider, they're just not there. And in addition, they're not family friendly, right? So they're not offering childcare during treatment most of the time. They're not offering transit to treatment. And most providers aren't going to be offering the kinds of specialty services for women that we'd like to see, like services for domestic violence. And that's potentially a barrier to engagement. And finally, there's similar misunderstandings to the child welfare system on the court side. They're also constrained by arbitrary timelines. And since we have these same possible prejudices against medication-assisted treatment, sometimes we actually see courts ordering parents. We say, okay, when you go off methadone treatment, then you can regain custody, which is the absolute opposite of what we want, because then parents are at increased risk for relapse. And it's, while they're maintained on treatment is when they're best able to appropriately care for their children. So how does this actually play out? How is the current system working in the United States? There actually isn't a lot of good research looking at what's happening on a national scale. So this was the second part of my dissertation research, trying to ask, how are we doing for all of these families across the country? And so what we did is we took data from a survey called the National Survey on Drug Use and Health between 2010 and 2014. This is a nationally representative survey of drug use in the United States and related problems. And we took from the survey a sample of adults who, based on questions about their symptoms, were identified as very likely meeting criteria for having an opioid use disorder. And we compared adults with at least one child in the home to adults without any children in the home on their access to substance use treatment, their belief that they need substance use treatment, and the barriers that they report facing to care if they say they needed treatment but they didn't get it. We did this using logistic regression. So what did we actually find? So what we find is that there's something like 820,000 US adults with an opioid use disorder who live with at least one child during this period. And we think that fewer than a third of them reported receiving any substance use treatment at all. So keep in mind, that's not medication-assisted treatment, the highest standard of care, which is only some subset of that. That's only 30% say they received any care in the past year. And that's comparable to adults who don't have any children, don't live with any children. And secondly, what we find is that about 15% of them say that they think they needed treatment that they didn't receive. So lack of perceived need for treatment is probably the number one barrier that adults actually face to treatment. And that's something I think that where child welfare services can certainly play a role, right, in helping folks motivate and recognize the need to go into substance use treatment. But in addition, we looked at, in that group of people who perceived a need for treatment, what barriers did they report to care, okay? So whether or not you have a child, financial barriers are the number one reported barrier to people who say, I needed treatment, but I didn't get it. But in addition, what we see is that there's a couple of barriers that are much more common among adults who live with children. And those are, first, access barriers. So that means like, you say you couldn't find the type of program that you think you needed, which is consistent with what we discussed earlier with this idea that many programs aren't offering the kinds of accommodating services that families need. And second, I want to highlight this one, stigma barriers are 4 times more common among adults with children. In other words, they're more likely to say they knew they needed treatment, but they didn't get it because they were afraid that somebody else, like a coworker or a neighbor, would find out about their drug problem. Okay, so what does all this mean, just to summarize? So most adults about 820,000 adults with an opioid use disorder live with a child. Most don't get any treatment. Not perceiving a need for treatment is probably the biggest barrier to care. But among those who perceive a need for treatment, there's financial barriers are the number one barrier to getting treatment. And then access barriers and stigma barriers are particularly common among adults with children. And that relates back to the kinds of challenges that we were discussing earlier, I think, looking at linkages across child welfare justice and child behavioral health systems and the sort of the stigmas that exist in those systems. So I want to briefly touch on sort of 5, where do we go from here? How do we get from that kind of underserved world that we're in to that better collaborative, families getting into treatment world that we want to be in, that's best interest of children? So first, for the first time ever, federal funding is being made available to states to try to prevent children from coming into foster care instead of just reimbursing states for the costs associated with foster care. And we need to make sure we're leveraging these funds to improve collaboration between child welfare systems, court systems, and behavioral health systems. And in particular, second, treatment programs, and we need to use that funding in this new collaboration to prioritize slots for child welfare-involved families in evidence-based substance use treatment programs, medication-assisted substance use treatment programs, because the research shows that we're going to get double benefits. There's going to be benefits for both the parents and child in those limited slots. And then we need to be complementing that treatment with specialized services that meet the needs of families, that don't just address the substance use problem, but that address the other holistic problems in the family. Third, we can build on the Medicaid expansion, right? So we've already talked a little bit about the Medicaid expansion today, but the number one barrier that families are facing financial, with Medicaid, we can overcome that financial barrier so that we're not spending child welfare funding or other public money to pay for substance use treatment as more families have access to Medicaid. Fourth, we've got to be rapidly evaluating state policies to see whether they're having benefits for kids, right? So we saw that some of the policies that are effective at preventing overdose probably aren't doing enough right now to meet the needs of children and families affected by the opioid epidemic. And we need to make sure we have policies specifically targeted at that. And finally, what I'm going to end with is sort of an ask for everybody here to think about what we can do to dispel the stigma associated with family substance use. And we've talked a lot about today, what is a public health approach? So I often say a public health approach has 2 components, evidence and empathy. And those are the 2 components that I think we need to use to dispel the stigma. Think about first, what do we know? What does the evidence tell us about what should be done for these families instead of what our gut tells us? And second, empathy. How can we think about what we can do as child-serving professionals to help these families heal, which is in the best interests of parents and children? I think that can really help to dispel some of the stigma barriers that we're talking about. So that's it for my talk. And so thank you again to Elizabeth, and no questions. There will be no questions. But we can talk at lunch or afterwards.